Hello, everyone. My name is Avajoy Burnett, and I am so pleased to serve as your moderator for this special podcast series called Johns Hopkins Medicine's Journey for Women of Color. This is my second year doing this. As a journalist, I know the importance of trusted sources of information. So that is why I'm excited to moderate this special series devoted to sharing the latest up-to-date information on three health issues of high importance to women of color. This year's series will feature discussions on ethnic skin and cosmetic surgery for women of color, menopause for women of color, and what women of color should know about multiple myeloma. All three of these will be released on April 8th in recognition of Health Disparities Month. I hope you'll find the time to make a plan to listen to each of these podcasts featuring Johns Hopkins Medicine physicians, and we cannot wait to get into this one. In this podcast, I will be discussing multiple myeloma and health disparities. My guest today is Associate Professor of Oncology, Dr. Carol Ann Huff, whose major research interests focus on the development of novel therapeutic approaches for the treatment of multiple myeloma and other plasma cell dyscrasias. How did I do with that, Dr. Huff?
You did wonderfully.
Okay, that was a tricky word. It's spelled very interestingly. So let's get to it here. I'm so happy to talk to you about this. Every time we have resources and information like this, it's really good for people to be able to learn more, especially when it has to do with health disparities that we don't always talk about. So, according to the International Myeloma Foundation, African Americans and Hispanic Americans have a higher incidence of myeloma and higher mortality rates from this disease. In fact, mortality rates are about twice as high in Black people as in white people. Dr. Huff, first of all, what is multiple myeloma?
Thanks for asking, and thanks for having me today. So multiple myeloma is a type of blood cancer. It's the second most common hematologic malignancy in the United States. And it's a disorder of what we call plasma cells. Plasma cells are normal. We all have them. That's how we make antibodies to fight off infections. But in multiple myeloma, something goes wrong with one of these plasma cells, and they start making copies of each other. And all those copies make the same antibody or piece of an antibody. And these are blood cells. They live in the bone marrow, in the bones, so they can cause bone problems. They can cause people to fracture bones. They can cause holes in bones. They can cause the release of calcium from the bones. And so people can get sick from having high calcium levels or having low blood counts because their bone marrow gets replaced by these cells. And so it affects about 35,000 Americans a year with this new cancer. The wonderful news, in general, we are doing better. But again, why we're talking today is we have done as well for women and men of color as we have for those who are Caucasians.
Oftentimes we hear these words. So I have heard of this disease before, but you don't know what it is. I've heard of multiple myeloma. I don't know if I've heard of it on TV commercials. I just don't know. What is it that makes you think that we hear these words, but we don't know exactly what the diseases are and just how serious they are?
I think the problem is that there aren't specific symptoms. And so people will often be more tired. They may have some pain. They may present when they have kidney failure or problems related to that, but there aren't a lot of symptoms that warn that this is happening. I should also say it's more common in older individuals. So the average age of diagnosis is about 69. This can occur in younger people, but is more common in older individuals. You've probably heard about it because there have been notable celebrities and notable politicians who are diagnosed with this. Probably also in part you're hearing about it more because in general, people are living longer because we've had a lot of new advances and new treatments available to help patients. And so more people are alive with myeloma now than were 5, 10, 15 years ago.
Does this occur more frequently in men or women of color?
It occurs more frequently in men in general. It's about twice as common in men as in women, but it is about 1.5 times as common in people of color as it is in Caucasians. So it is more common in men of color, but also women of color than in Caucasians.
Why is that?
We don't entirely understand why. There are generally not familial clusters of myeloma. Most of the time it happens randomly. There are some small families, but there is data that we and others have worked on that suggests that actually obesity can contribute to the development of multiple myeloma, and looking back to weight in high school age, but we don't entirely understand the disparity. In general, interestingly enough, many times the disease is not as aggressive in people of color, but unfortunately, they have not received comparable therapy. And that is the biggest discrepancy why mortality is twice as high.
Okay, so we're going to talk about that issue of not getting the proper treatment, equal treatment. I don't know if that's the best way to describe it, but maybe just not having the access. But
Yes.
before we get to that, what are some of the risk factors? You mentioned something about sometimes your health factors as a young person could contribute to that. So what are the health factors?
The best that we know that has been correlated has been weight and obesity. We unfortunately do not have a really clear understanding of why some people get myeloma and others do not. The best studies that have been done have been looking retrospectively at people who are diagnosed with myeloma and then looking back and taking health histories related to that from that perspective.
We talked about the risk factors then and the fact that we don't know a lot about them, but is there a difference in the risk factors based on race?
We can't necessarily say that. Again, most of these cases are sporadic, so it's difficult. I should say other risk factors, not health related, but are exposures to high level of radiation, high levels of petrochemicals, high levels of pesticides. So those have all been associated with the development of myeloma. There is increased myeloma in the 9/11 survivors. There's increased myeloma in those who have survived atomic bombs. But we really can't necessarily say there's disparities or differences based on race associated with those risk factors.
As an oncologist, how is this disease diagnosed?
So the disease is diagnosed through a combination of blood tests, urine test, bone marrow biopsy, and imaging studies. But really the diagnosis is not one test. It's a combination of finding these abnormal plasma cells, which we see hints of in the blood and the urine, but you actually see them on a bone marrow biopsy. And so it's a combination of all of these put together to make the diagnosis, because there is a precursor state to multiple myeloma called monoclonal gammopathy of undetermined significance, which is a big mouthful. We abbreviate it MGUS. And that is very common. That is 1% of people who are 50, upwards to 5% of 70-year-olds will have this. And so when you see those abnormalities in the blood, it then prompts you to consider whether these other tests are needed. And so it exists on a spectrum from a asymptomatic state all the way up to a symptomatic cancerous state that people need treatment for.
I want to talk to you more about the diagnosis. Is there normally, do people get misdiagnosed? They go in, they think they have another issue, and then they end up finding out sometime later that it is multiple myeloma and not something else?
I would say people maybe rather than misdiagnosed are underdiagnosed. They may have symptoms or abnormalities, but it's not appreciated that it is multiple myeloma. So they don't get all of the testing done. They might be a little bit anemic and say, I've been anemic all my life, and someone doesn't work up the anemia further. They may have some pain and the pain doesn't get evaluated until things are worse. That tends to be more what I see than actually people having been misdiagnosed.
When we did this last year, one of the diseases we spoke about was sickle cell, another blood disease. And I learned so much about how it's treated, in particular, because I also have a family member who struggles with that disease. So what are some of the treatments for multiple myeloma?
Yeah, so the way we treat multiple myeloma is with combination immunotherapy and some chemotherapy drugs, although they're not what most people would conjure up with regard to chemotherapy. And by that, I mean they're often oral, they may be subcutaneous shots, they don't tend to cause people to be terribly sick. And so we treat patients with 3 to 4 drug combinations when they're newly diagnosed for a number of months, and then often follow this with a stem cell transplantation, which is where where there becomes a bigger disparity. There's a disparity in the initial therapy and patients not getting the full complement of drugs, not getting 3 or 4 medicines. And then there's even fewer patients going on to get stem cell transplants. And then we maintain this. So this is a disease we can't cure, but we can keep people alive for really long periods of time. And so we treat this with therapy that is ongoing and continuing people on maintenance therapy. And so that is another area where therapy differs because treatment may get stopped. And when treatment is stopped, patients don't do as well. We keep using these therapies. Eventually those don't work and we move on to other treatments. But there's some very exciting developments in the form of, you may have heard of these newer immunotherapies called CAR T cells. So we have CAR T cells for myeloma, and we have some unique new antibodies called bispecifics. And so these are therapies when in the past nothing else had worked. And these are working, giving 70, 80, 90% of people, putting them back into remission for several years at a time, which is really remarkable advances for patients.
When you mentioned the different forms or potential forms of treatment, and I heard something about a chemo drug, I know it could be a combination here or there. One of the things that popped into my mind is, what are the side effects of those drugs? So what are some of the side effects that people can experience if they're going through this treatment?
Every drug we use in general for anything has its own sets of side effects. Most of these drugs actually are quite well tolerated. They may cause some changes in your bowel habits. Sometimes people get a little bit of diarrhea or constipation. None of those are usually terribly significant or dramatic, and we can manage them. They can cause some neuropathy. So what I mean by that is tingling or numbness in your fingers or your toes. And again, we monitor for that and we can adjust the doses if that's starting to happen. One of the drugs, which is an oral group of drugs called IMiDs, can lead to higher risks of blood clots. So we monitor closely for those. We put everybody on at least an aspirin to help prevent developing blood clots, and we monitor closely. And then another one is an immune therapy that sometimes people have allergic reactions to, which tend to happen right around the time of the dose. And if they don't happen, then they don't happen. And we can pre-medicate and essentially prevent many of those reactions. So most of the time people come to the clinic once a week for a short period of time, and they're able to continue working or living their lives or doing the things that they want to do. I should also say we add in bone strengthening medicine, because one of the things this can do is reduce the bone strength and increase the risk of fractures. So we add those medications in, and they're given once a month, either by an IV infusion or by a shot. But generally, people are able to go on and live their lives and not be significantly disrupted. That's not to say everybody, but the vast majority of people, I don't tell them to stop working. I tell them to continue doing things and planning, and we will work around those things.
For the disparities in treatment, we know sometimes there are cost aspects to treatments for people who may be underinsured. People sometimes have to prioritize certain treatments that they may be getting because they can't afford it. How difficult is it for people to get treatments for this if they are not fully insured? What are some of the issues you're seeing with patients with that issue?
There are really very good assistance programs out there, and I think it's a matter of accessing them. So we have an infrastructure at our institution that helps patients access those programs to assist with co-payments. That has not been the biggest disparity at our institution. I think the biggest disparity is getting people to myeloma centers of excellence and having people know about and access these programs that are available. People are able to get help and get assistance. Many of these drugs, there are foundations that provide support. There's also pharmaceutical companies that provide support as well to help with that. Not to say that that isn't a part of the disparity, but I think oftentimes it seems that people aren't offered the full complement of treatments.
We are talking about health disparities, and we are talking about issues surrounding women of color. So are treatments for multiple myeloma different for women of color?
They shouldn't be. They should be exactly the same for all patients with myeloma, independent of race, gender, ethnicity.
That's very important to note. The reason why I ask that is because people are different. Their bodies are built differently. And we talk about sometimes treatments only being tested on men and then being used across the board for women. So are you finding that in this particular stage of our lives and research, there is now more focus on equity and parity, especially when it comes to women and women of color.
Absolutely. So there is definitely more focus on parity in these trials, and we continue to need to enroll more women of color, more people of color in our trials. There are actually ongoing trials in myeloma that are specifically trying to enrich that subgroup of patients within the trial enrollment to make sure that the metabolism of these agents is the same and that the toxicities and the side effects are. But many of the more recent myeloma trials, while they don't fully reflect the full spectrum of patients with this disease, they are approaching 20, 30, 40% African American or people of color enrollment into these trials, which is really rather remarkable compared to many of them where in the past things have been 10% or less. So yes, there is very much a focus on doing this.
You went right into my next question about trials. I'm curious as to, are there trials that are going on right now that people should know about, and how can they find out about them?
There are many, many trials that are going on right now. I couldn't even tell you how many there are. I think a very good resource is to go to the NCI Clinical Trials website and look for myeloma. There are two very good patient support foundations, the International Myeloma Foundation and the Multiple Myeloma Research Foundation, that also have lists of trials. I think asking is very important. Asking your provider, are there clinical trials that I'm eligible for? There are not as many trials in the newly diagnosed setting at this point in time because we actually have regimens that have 95+% response rates. And so much more of the work is being developed for patients whose myeloma has come back in the second, third, fourth, fifth, sixth lines of therapy. And there are many, many trials that are open looking at all different kinds of approaches and not just looking at escalating therapy, but actually looking at de-escalating therapy. So are there patients that we can give less treatment to over time? Because that's very important because as I indicated, we tend to treat people indefinitely, which is we've learned they live better, but we're sure that not everybody needs that. What we don't know yet is how to identify who doesn't need all of that treatment at this point in time. So there's very active trials ongoing looking at those options.
I want to go back to the disparities that you talked about in age and the fact that the average age, I thought you said, was around 69 or so is when people get this disease. Why is that?
Well, the best that we can surmise is that plasma cells are cells in our bodies that all throughout life have to make new antibodies. And they do that by rearranging their chromosomes or their DNA within the cells. And there are specific areas that this gets messed up, if you will, over time. And so the belief is that over life, as we do this more and more, there's a greater probability for making mistakes and therefore a greater probability for accumulating these abnormal cells that become cancerous. And that is why we see this as a disease of older individuals. It generally is not one genetic abnormality that happens. It's generally more than one. And so it's thought to be mostly accumulation of these.
Okay, so would you say this disease is more genetic or environmental?
It's not genetics in the genetics you've inherited from somebody else.
Okay.
It is genetics of the cancer cells that have become abnormal, and so they grow abnormally. But it is not something generally that is passed down from generations, which is what people usually are asking when they ask me if it's genetics.
Okay, I'm in good company. I learned something new today. But carry on with that. I'm intrigued by that.
There are definitely clusters. There are definitely exposures when people have petrochemical exposure, radiation exposure, pesticide exposure. There are clusters of people who have myeloma and have diseases related to myeloma. And so I suspect it's probably a combination of environmental and age-related genetic changes in the cells, probably more than anything else. It's not a disease like breast cancer or things where we've clearly identified a gene that if it's mutated, half the people will get breast cancer. We don't have that in myeloma. We and others have conducted an analysis of what's called GWAS, so a genome-wide accessioning to look at genetic abnormalities in African Americans. So we did the study around the country with a consortium looking at over 2,000 people's blood to try to identify signals of areas that were abnormal abnormal. And while we did identify a few signals, they were not terribly strong to say this is the culprit for why this occurs. It's also interesting because the types of myeloma differ somewhat in people of color than in Caucasians. And again, for reasons we don't understand, oftentimes it's not as aggressive and easier to treat, and yet they don't get the same therapy. And so the outcomes have not been as good.
There are a couple of more things that I want to ask you about. We are now in an age where we're very cognizant of what we do today and how it could impact us for tomorrow. So many people may be asking a question of what can I do today to prevent my future 69-year-old self from developing this disease? You talked about exposure to certain things, and you talked about the possibility of obesity being a potential issue. Are there other things that people should be looking out for and should be practicing to help reduce the possibility of developing multiple myeloma?
I wouldn't say it's just to reduce the risk of myeloma. I would say that it's good to maintain a healthy, balanced diet, rich in fruits and vegetables, to exercise, to keep your weight and your cardiovascular state good for all the things that can help with. Again, reducing exposures to the things we know of can be helpful. But honestly, what I tell most of my patients is the best thing to do is be in the best shape possible so that in the event that something like this happens, you'll be in the best shape to have treatments and move forward. So I can't clearly tell you that if you don't do X, Y, or Z, you will not get myeloma.
Is that a bit frustrating for you as a scientist?
It is a little bit frustrating. It is, especially we also see patients who have the precursor state. What can I do to prevent myself from getting myeloma? And I can't give them anything to tell them, what can I do to help prevent this? I can't give them anything clearly other than my good overall health recommendations.
Doc, how long have you been in this field?
Probably close to 30 years at this point in time. No, probably 20 years, I should say.
What advancements have you seen in those?
Oh my goodness. When I first started, this was a disease for which there were, I don't know, maybe 5 medications, and the average survival was 3 years, and people didn't get into deep remissions. And the drugs we gave were truly chemo drugs like most people would think of, where their hair would come out, they'd be sick, they couldn't work. Now we have people living 10, 20 plus years. They live good lives. They have medicines they can tolerate, they can work. It's just been remarkable. We've had probably 15 approvals through the FDA, and there's actually an ODAC meeting. Well, by the time this airs, it will have happened, but the day that we're recording this, there's an ODAC meeting happening looking at moving these CAR T-cell therapies perhaps even earlier into lines of therapy. So it's really been dramatic, and it's so nice to be able to help people do better and offer them so much more, and offer them therapies that are not only work better, but have much better side effect profiles.
Did you see my jaw drop?
I
when
did.
You said the life expectancy was 3 years, and now people are living for maybe even more than a decade?
Yes, routinely.
Oh, that's incredible. Okay, so this may
But
be
we still need to do better in our people of color, our women of color, to make sure that they have access to these therapies and they receive them. That would be my one takeaway. Whatever we can do to get people, have people reach out, get people to centers of excellence so they get therapies and have the opportunity to receive them.
What kinds of coordination is there between doctors like yourself and primary care physicians to alert them about what to look out for and how to get their patients to you before it may be too late?
We put on CME programs, reaching out to them individually. I think that, many times.
Stand for?
Oh, I'm so sorry. Continuing medical education. We do education programs by webcasts, by podcasts, by in-person meetings with all different types of clinicians, getting the information to primary care doctors, getting the information to oncologists. I would say that many of our patients do come to us directly from primary care doctors, but oftentimes myeloma has become quite complicated to treat. So many of the patients who come to us from other oncologists. So it is important that patients, when they get to an oncologist, not only just see their community oncologist, but seek out a myeloma expert to be seen, to collaborate. So we collaborate very closely with our community oncologists, and whatever they can do there, they do there. But what is needed to be at a center of excellence, that we provide that therapy and that expertise and guidance. Because myeloma, while there are many people with myeloma. It's only about 1% to 2% of all oncology. So for a community oncologist to keep up with all the advances in myeloma, it's very difficult. And so they rely on us, but we have to get them to us for that.
I want to go back to symptoms and screening and how people find out. Is it through your annual physical where you do blood work and then they're like, oh, here's something that's abnormal? Or is it through pain?
It's a variety of different ways. I would say probably 10 to 20% of people through their routine physical are found to have blood abnormalities. Usually anemia or a high protein level in their blood would probably be the two most common things that prompt an evaluation that may ultimately lead to a diagnosis of multiple myeloma. Probably another 10%, 20% of people already know they have a precursor state, so they're being followed because their blood work showed an abnormality that led them to be seen and evaluated. But the remaining 50, 60% of people who have symptoms, they may have pain, they may have tiredness, they may have developed neuropathy, tingling, numbness of their fingers or toes that prompt them to go to their doctor to be evaluated. They might break a bone. They might show up in an emergency room with a high calcium level, confused and sleepy, or they might develop kidney problems and see a kidney doctor or so forth. So we like to find them when it's just blood work at a screening physical. We don't screen for myeloma because it's not that common of an entity, and most screening tests to look for particular things like pap smears and colonoscopies are done because they've been shown to improve survival. Because this is not that common, it certainly wouldn't amount to a screening test specifically for this at an annual physical.
I wonder, Dr. Huff, what is it like when you are talking to a patient who's finding out for the first time that they have this disease, or possibly for the second time when they're just coming to you as an expert in this field? What are their emotions like?
I think the emotions run the gamut. Most people are scared, probably is the emotion I see the most. And, for many people, it's the first time they've thought about mortality. We all know we're going to die, but somehow it's all in the future until something like this happens, and not just myeloma, but any of these kinds of conditions. And so what I try to do in my very first visits is, one, reassure them that we're a partner and we're a team. I share with them the many advances that we've had in myeloma and how people are doing very well, and that we will always do the very best we can and keep them on the cutting edge and continue to evolve and continue to advance things. And that while not curable, this is very treatable and that we're going to move things forward. And by and large, at the end of the visit, people feel better.
Yeah, I just want to reiterate about our podcast series here. It's Johns Hopkins Medicine's Journey for Women of Color. We're focusing on women of color and disparities that affect women of color, but not just women of color, our communities, because there is a ripple effect. Before we go, what's your advice? What's your one takeaway for women of color, especially with regards to multiple myeloma?
I think my one takeaway is be an advocate for yourself. If you have things that you're worried about, please reach out to your primary care provider, your doctor, and ask questions and be evaluated, and know that we will do everything we can to help you live the best possible life if you have myeloma, as long as possible, enroll you in trials and give you the most state-of-the-art therapy, and that we are here with you.
Oh, family, because it's all about
Family.
the community. Tell
Absolutely.
me about your advice for family as well, especially for moms who have like all of these people who are depending on them.
So my advice for family is wrap yourselves around your family member with myeloma or any other condition and be there to be helpful and supportive. I think there are resources. We are there to help, and we will work to get whatever support we possibly can for you.
I loved this conversation. Is there anything else that I should have asked that I did not ask?
I don't think so. I think this has been a wonderful time, and I really enjoyed talking with you.
Do you know what I like about these things? I like the fact that I am not a medical journalist. So I get to ask the simplest of questions because I'm not in that field. And perhaps that will help people like myself, which is possibly the majority of the population who aren't medical scientists.
And what I actually tell all my patients is that there are no silly questions or dumb questions. They only ask them. Ask all of them. We will get them answered for you. So please never be afraid to ask a question because one, the answer might surprise you, and two, it helps other people. So thank you for giving us this opportunity.
Oh, thank you too, Dr. Carol Ann Huff. We are so happy to have had you here today. And I want to remind everyone who you are. Some of your major researches include interests that focus on the development of novel therapeutic approaches for the treatment of multiple myeloma and other plasma cell. I've got to get that word.
Dyscrasias.
Dyscrasias. Thank you. And thank you to everyone for joining us here today for this special podcast on multiple myeloma for women of color. It has been my honor to serve as a special guest moderator for Journey for Women of Color. Thank you so much once again, Dr. Carol Ann Huff, for being my guest today, for being our guest today. Johns Hopkins Medicine, A Woman's Journey, would like to thank Astellas for its unrestricted educational support of this year's Journey for Women of Color podcast. If you have enjoyed today's discussion, please check out A Woman's Journey's website at hopkinsmedicine.org/A Woman's Journey for information about upcoming free webinars. Subscribe to A Woman's Journey's Insights That Matter podcast series and sign up for A Woman's Journey's monthly email. Everyone, thank you so much for being with us today.